Now I am going behind. See this, the frontal recess started. Frontal recess started. Can you see this cell which is pneumatized? Hello?
Yes, sir.
This is pneumatized cell without any disease, and what it has given? It has narrowed the frontal outflow. See this? See this frontal outflow is here, which is blocked by this cell. Now, where this cell is attached to, look at the sagittal. Look at the sagittal. Can you see this cell?
Yes, sir.
See, the cell is not infected. Cell is not blocked. But see this cell where it is. See this cell, this cell, this cell. Here is the site of the bulla, and this is trying to go inside the frontal sinus. This is frontobular cell. Can you see this?
Yes, sir.
And this is what it has given. It has narrowed the frontal sinus out. Had there been frontal cell, it would have been attached like this. And then you would have to go behind that. Here this cell, see this pneumatized cell attached behind, and this outflow is narrowed anterior to it. Here you cannot afford to go behind that cell, and you have to open up this cell and flush it. I hope it is very clear.
Yes, sir.
Yes, sir.
See how vital is this sagittal cuts. This is a normal cell. Once you open, there is nothing, abnormal inside. This cell is being aerated, but this has blocked the frontal sinus outflow, which has resulted into serious frontal sinusitis. I hope it is very clear.
Yes, sir.
So in this patient, this was another useful finding. Now, after that, another useful finding, let me tell you. Another useful finding. Now we have gone in, this is the cell in the frontal recess. Frontal recess means behind. Far behind. Anteriorly, there was no cell, it is behind. And now is the beginning of the cribriform plate. And can you see on both sides? Can you see both sides the turbinates? Different pictures of both the turbinates. This has a great impact again. See, both the turbinates are pneumatized. Can you see? And see this. This is the turbinate pneumatized. This is known as concha bullosa. Can you see? And this is full of disease, unaerated. Concha you may find aerated once it is receiving aeration, and this is no ventilation, and see it is inflamed. Can you see? Hello?
Yes, sir.
See on the opposite side, the entire turbinate lamella is pneumatized. This is lamellar cell. This is laminar cell. The turbinate itself, can you see the entire length of the turbinate?
Yes, sir.
Is pneumatized right up to the skull base. You have to deal with it very carefully, otherwise can lead to fracture and CSF leak thereof. See the entire cell turbinate lamella is pneumatized. See very clear? In contrast to the opposite side, see opposite side, the upper lamella is absolutely clear, and this lower one is pneumatized, concha bullosa. I hope you appreciate this,
Yes,
what
sir.
I am trying to say. This is lamellar cell, and this is concha bullosa. Another important finding is, see, because of this CCAD presented with olfaction loss, because the obliteration of the frontal recess with some anatomical abnormality. See this anatomical abnormality, what a big cell it was. It is predisposed to the frontal sinusitis. These are the two reasons why this patient is having problems. Additional problem, the turbinates are laterally placed. Can you see this? See, this turbinate is so laterally pushed because of the disease medial to it. Hello?
Yes, sir.
Hello?
Yes, sir.
Yes. And as you go behind, That was the minimal, osteometal blockage on the right side, minimal on the left side. And now as you go behind, that's the level of the rostrum. See, this is broadening, rostrum, and it has blocked the ostia.
Rostrum is pneumatized.
Yes, rostrum is, this rostrum is pneumatized here. Right side is almost completely opacified as compared to the left. So this is the picture. Now, another important thing, once you find disease medial to the middle turbinate, in such a situation, when the patient presented with olfaction loss and the lamellar cell on one side, which has to be thoroughly flushed now, because this lamella is not a very stable lamella, and it has to be cut to prevent a floppy turbinate. Opposite side is concha. Again, you have to open up and it may lead to floppy turbinate once you remove the lateral part of it. So you may have to do a partial turbinate resection in this case. That will help us opening the olfactory area as well. Generally in CCAD, you preserve the turbinate. But your concern is the olfaction, you have to open up the access to the olfaction. So we will partially trim the turbinate. In general, any patient having disease medial to the middle turbinate, you have to do a partial turbinate resection to allow the topicals to reach to the olfactory recess uninterrupted. A lot of interesting finding in these cases, in this particular case also. Any questions? Hello.
Sir, in females, hello,
Yes.
hello, sir.
Yes, please.
Yeah, in females, sometimes we see more bleeding during surgery. Like, any precautions?
Not like that. It depends upon if you are on any medication. Is affecting. It depends upon the preparation also, depends upon the hormonal status, so many things. It's not, you can't say aggregate as a statement for everybody, but yes, it can.
Sir, you will address the septal spur also in this case?
Pardon?
Septal spur, you will address?
Yes. Septum and turbinate